On behalf of Association of American Physicians and Surgeons, Representative Brown was kind enough to join us, and he's got some ideas that we believe are taking the whole idea of medical practice in the right direction, Option Act in particular. So I'll step aside. Representative Brown.
Thank you, Dr. Smith. I really appreciate this opportunity to be here today and appreciate y'all coming. I believe there are several very sacred relationships, and I think that one of the most sacred confidential relationships is that of a patient with their doctor. Federal policy is destroying, and it has been destroying that relationship for a long period of time. And not only has federal policy been doing so, but also the insurance industry, through their policy, has been destroying that doctor-patient relationship. Because what we've done is we've injected a bureaucrat, whether it's a federal bureaucrat or an insurance company bureaucrat, between the doctor and the patient. And it has to stop. We need to build a system where the patient, along with their doctor, makes all healthcare decisions. And with ObamaCare now, we have a law that not only is going to continue to destroy the doctor-patient relationship, but it's going to destroy the quality of healthcare. It's going to destroy budgets, whether it's family budgets, business budgets, states budgets, or the federal budget. And it's going to destroy our freedom. We already see an attack upon that as the Secretary of Health and Human Services, Kathleen Sebelius, made a tremendous attack upon religious freedom and conscience when she said that all health care plans are going to have to give free birth control pills, free pills that are designed to do nothing but create an abortion, and free sterilization, which flies in the face of the religious conscience and religious freedom of Catholics and many others across this nation. But this is just the first step. We must repeal Obamacare. And we must replace it with something that empowers patients so that patients can go to see their doctor and make decisions along with their doctor, where we can lower the cost of health insurance, where we can provide coverage for all Americans, and where we can save Medicare from going broke. The Patient Option Act, H.R. 4224, will do just that. It will indeed lower the cost, makes health care cheaper for everyone. It's also going to provide coverage for all Americans, and it will save Medicare from going broke. And it's the only plan that any member of Congress has introduced thus far that has that overarching long-term effect. Now, what does the Patient Option Act do? It does a number of things, some of which have been floating around here in the Republican circles for a long period of time, such as cross-state line purchases of health insurance. Association pools where people can join an association and have multiple insurance products that they can purchase. The kind of insurance that best fits their family needs. But we tweaked that a little bit in my bill in that we took the Health and Human Services out of that decision-making process, where any association can be established, as long as it's one that is a 501c3 or even a 501c3 eligible association. Any association can offer insurance products to its membership. We do something that's very novel that I'm not seeing around here, in that we give doctors a tax credit for seeing indigent patients. In fact, I'll give you an example of how this works. I was talking to a physician who practices in a very upscale area. Most of his patients are very wealthy. And he told me, Paul, if you put that in your bill, I'll schedule 2 days in the week and see nothing but indigent patients. We expand health savings accounts so that people can put $10,000 a year tax-free into health savings account. And they own those dollars. They control those dollars. The federal government doesn't. The federal government doesn't control it. They own it and control it themselves. In fact, when they pass away, any residual in that health savings accounts will go into their estate. We create a Medicare health savings account that the Department of Treasury will fund and will give Medicare patients premium assistance to buy catastrophic care on top of that they decide themselves. They go into the marketplace. They can go across state lines, they can go into an association, they can buy whatever kind of health insurance is best for them. And again, they'll own those dollars so that when they pass away, those dollars that they have invested over their work life will actually go into their estate. So they're beneficiary of those health savings accounts, both on the Medicare side as well as the private side, will go to the heirs of that estate. We reform EMTALA, the Emergency Medical Treatment and Active Labor Act, so that hospitals can set up a screening process and don't have to treat patients that come in the hospitals that don't have true emergencies. And the hospitals make those decisions of who those people are and how they do that. But EMTALA itself is absolutely harming the economic viability of particularly small rural hospitals. It has to be reformed so that we can continue to have the availability of hospitals all across this country, particularly in those rural areas. So it's a big bill. It's 51 pages. That, along with a companion bill that I introduced along with several members of the Republican Study Committee that deals with Medicaid and the State Child Health Insurance Program. What we do in that one, we freeze the prices, or we freeze the spending at 2012 levels, and we block grant the money to the states. The states run the programs themselves with no strings attached. And if you think about it, with my Patient Option Act and with our Medicaid S-CHIP bill, we'll eliminate the need for the Center for Medicare and Medicaid Services. Totally eliminate that part of the federal government that is destroying the doctor-patient relationship. We must have policy that empowers patients, and that's what the Patient Option Act will do. Freedom Works has endorsed it, said it's the best health care plan out there. We had the healthcare expert with Forbes magazine wrote an article about it, and they said some good things about it. Redstate.com recently has endorsed my plan. We have a number of individuals, particularly in the healthcare field. I have doctors all over the country say this is the kind of healthcare plan that we need. So we're going to continue to work to try to empower patients. And that's what the Association of American Physicians and Surgeons is all about. It's about looking to find where doctors can provide good quality care to their patients without all this government intrusion. It's government intrusion that has run up the cost of health care. We've got to get the regulatory burden off the healthcare system to further lower the cost of health care so that my colleagues, I'm a family doctor, my colleagues and I can practice medicine, give the kind of health care to our patients that we're trained to do. It's getting to be more and more difficult to perform those services to my patients, to all physicians' patients in this country because of the federal government. We've got to get the federal government out of the business. And that's what the Patient Option Act will do. So I'd appreciate y'all's support. I appreciate AAPS for coming and holding this meeting. My staff will be glad to answer any questions. The bill number is HR 4224. I'd like for y'all to look at that and get your bosses to embrace it. And I encourage my doctor colleagues all across this country to tell their patients to contact their member of Congress, both in the Senate as well as in the House, and demand that the Patient Option Act be the health care policy that the Republicans bring forward in this next Congress so that we can empower patients, we can lower the cost of health care for everybody, that we will save Medicare from going broke, and will provide coverage for all Americans, as the Patient Option Act does. Thank you so much, Dr. Smith.
Hi, I'm Dr. Madrigal. I'm the president-elect of the AAPS. I'm going to tell you a little about my practice as it kind of relates to what Dr. Brown said about patient-doctor relationships. I am a small town doctor in Texas. I don't take any insurance, and I never have. I did take Medicare, and I opted out of that 5 years ago. The reason I do then, I do internal medicine and pediatrics, so I'm board certified in both, so I'm kind of the small town country doctor. I make house calls, for real. Make house calls. We give discounts to teachers and preachers. If patients get cancer, we see them for free. We see missionaries for free, unless they're Baptist, and then it's kind of up in the air. I'm just kidding. We give discounts, or we see for free like refugee kids. Like we have 3 kids from Haiti right now. If a family takes in a kid who can't live with their parents and they're not in the foster system yet, we see them for free too. The reason we can do that, though, is because I don't take insurance. If I took Medicare, it would be a felony for me to see these kids for free, or these adults for free. I don't want to be a felon. I just want to be a doctor. I want to take care of patients. And getting the government out of my practice just puts me and the patients one-on-one. If you put the government in there, there's a big thing in between there. The reason why this works is because I answer to the patients. Everything I do is between me and the patient. It's not between me and the government. It's not between me and an insurance agency. What I'm afraid of is with this new ObamaCare is that everything will be mandated. For example, last week I had a lady who came in. She had the worst headache of her life. She couldn't see out of one eye. It was this weird blinking light thing, and it sounded like she had an aneurysm. So she had insurance. So we called her insurance company and said she needs an MRI right away. They said, we can't find her, give us a couple hours. Okay, so I ordered the MRI for like 3 hours before then. They couldn't find her. They never called us back. In the meantime, I have a guy literally who has a heart attack. I have to call the helicopter and fly him out. I'm still waiting on this lady I'm really worried about. They never call us back. We call them. They said, oh, we found her. Okay, can we have the number so we can get this MRI? Well, that has to go to my supervisor, and she's going to let me know, and she'll do an email. So it's this funny thing of, they're not telling us no, they're just telling us not yet. And you know when you try to tell a kid, like in one of your stories, no, not no, but just not now. Can I have a cookie? Not now. But what you really mean is no. That's what was happening. So finally, the time she had her MRI was gone. They couldn't squeeze her in that day. We had to wait overnight, hoping she didn't actually have an aneurysm and die. The next morning, they called and said, okay, we have the approval, but you have to have treated for a migraine first. Like, I don't think she has a migraine, and if she has an aneurysm and I treat her for a migraine, it can kill her. I'm not a doctor, we're just telling you we don't approve that unless you've already treated for a migraine first. That's not going to work. That's going to end up having a lot of dead patients and a lot of patients suffering. And I can tell you that even though this lady thought she had great insurance before she ever really had to use it, she didn't. And this was a big, great insurance company that would pay 100% if you can wait a day and not die, and if you follow all their rules first. Because otherwise the doctor's in this bad situation where they either have to lie or the patient doesn't get what they want. Finally, she gets the MRI. She actually has a tumor, not an aneurysm, which is good in a weird sort of way. And when she got the bill, her deductible was $400. Guess how much it would have been if she had paid cash for that MRI? $400. So if I had known that they weren't going to pay for it, I could have told her, look, just pay the $400. Let's see what's going on and get it right away. But because she has insurance, it made me have to delay her care, and her out-of-pocket's the same. So that's kind of the myth of insurance. There's a lot of examples like that. Like insurance companies a lot of times won't pay for the medicine I prescribe, like say for heartburn or a sleeping pill. They won't pay for a good sleeping pill that's not addictive unless you first try one that's only $5 first. Well, you can afford that $5 one without even having insurance. So why do you need insurance? And then I put you on a sleeping pill to make sure it doesn't work and you get addicted to it. What's the point of that? There are a lot of things like this that are keeping us from being able to actually take care of our patients. So one of the things we advocate is, one of my other colleagues put the 3 C's. I actually would like to change it to the 4 C's, which is choice, cash, because when you pay cash, things are cheaper, charity, and catastrophic. So choice, giving the patients a choice, letting them go to the doctor they want to, letting them decide with the doctor which medicines they want and which care they need. Number two, capitalism and cash. If you pay cash, things are so much cheaper. For example, I do a CBC at my office, which is a complete blood cell count. At my office, it's $15. If you go to the charity hospital around the corner, it's $150. So the charity price, that's not the real price. That's not how much the insurance companies pay. That's just how much they charge people. Big difference, but it's not fair when the price is it's actually less than $15. So if you pay cash, you can actually get better deals on things, and you can actually get closer to what the real price is and actually know what the real price of your medical care is. Charity goes without saying. Doctors like to do charity. I don't know a single doctor who doesn't like to take care of people who need it. The problem is right now with the current system, it's against the law. Again, it's actually a felony for me to see people for free. Some people who are really sick, even if they have great insurance or they're covered by the government, they still have a lot of copays. Or even with Medicare, you have a $200 deductible. If you're really sick and going through a hard time, you might not be able to afford that. But a doctor can't legally write that off right now, and I don't think that's fair either. And then last, catastrophic. I really like Dr. Brown's bill having that HSA that you can put more money in, and that can actually be your safety net, and you can use that how you see fit. That, I think, is one of the big saving graces. If you pay cash for things, you might not even need to use that. If you go to the doctor and it's only $75 and your medicine's only $5, you might not need insurance, especially if you only go once or twice a year. But if something really bad happens, it's nice to be able to have a safety net. The other thing about this that doctors absolutely hate is how much red tape there is. Right now, there's this thing called ICD-9 codes, so every single patient you see, if you take insurance or Medicare or Medicaid, the patient is a 5-digit code. Right now, there are 3,000 codes. At the end of this year, there's going to be 87,000 codes. That's a lot of codes. That's a lot of numbers that, again, make patients, instead of being the patient, hey, here's a sick patient who has diabetes, it's a 250.00. These codes, it's also a felony if you put the wrong code. There is a code for a bite by macaw versus bite from parrot. There's a code for being struck by a turtle. There's a code for being struck by a turtle a subsequent time. I'm not kidding. There's a code for burn from fire while on water skis. Okay? So somebody took all this time to make these codes that doctors have to go through. There really is. That doctors have to go through when there's really no such thing. Like, I did a big search on the internet to see if anybody who had ever been burned while on water skis, and I couldn't find it. If it's not on the web, it probably has never happened. But these things actually make our job so much harder, especially because there are these very severe punishments if we do it wrong. Plus, just trying to look up a code for struck by turtle when you're really trying to find like aneurysm or really bad headache or weird flashing lights. These are made by people who aren't really in tune with what we do on a daily basis. When you start putting the government in there, the whole idea of private practice totally goes out the window. Right now, doctors are starting to be required, or they are required, to do electronic medical record where everything you tell them goes straight to them. Again, then your relationship with me in the office isn't private anymore. If they know some indiscretion you had when you were in college, that's not private. That goes to them. And sometimes you don't want the government to know or anybody to know a lot of stuff. So again, it's taking that security of having a true doctor-patient relationship out. Okay, so the other thing I want to talk about is what patients fear. So I put this on my Facebook and it just blew up. So the thing I asked my patients and my friends, like, what do you fear about the more government in medicine? And some of the things they fear are being treated like a 5-digit code, or I guess it's a 7-digit code, calling for a doctor and getting an answering machine that tells you to call 911 instead of getting care. If you call your doctor because you're sick and they tell you to call 911, that's not getting care. Everybody knows to do that. That's not care. They fear dying while waiting in line. They fear that it will become the way it is in Canada or Europe, where there's only so much care, so you have to wait your turn to get the care you need. They also fear that they won't have doctors who care, because as doctors have to see more and more patients to make their overhead, they can spend less and less time with patients. The number one thing we do as doctors is listen to patients. 99% of how we make a diagnosis is based on what the patients tell us, not the test, not the x-rays. It's really what the patient tells us, how we figure out what's going on. And if you don't have that time, you really can't do a good job. And then one of the things that was really interesting is that they're afraid that the greater good will come before the individual. So one of these ladies wrote that she had breast cancer. She said she had a mammogram and it picked up breast cancer in the very early stages. But she said if the new guidelines where they want to only allow mammograms every other year had already been in place, she wouldn't have had that mammogram and she absolutely would have been dead. So they fear that if they don't meet the criteria or they don't meet the exact criteria that the insurance company or the government set up, that they can die. Well, the thing is about cancer is it never follows the rules. That's kind of the whole thing about cancer. It doesn't go A, B, C, D. It goes out like a shooting star. So the other thing she said is when she had her mastectomy, they actually went ahead and did the other breast at the same time because this was so invasive, and it turned out she had early breast cancer in the other breast too. And she said, I fear that I wouldn't meet criteria for that. The only reason they did that is because I talked to my doctor and I wanted it, and that probably saved my life too. So patients are fearful because, again, even though some people have good intentions of putting up what most people do, it's not what everybody does. Not everybody who sees flashing lights and has a bad headache has a migraine. Most of them do, but not all of them do. And those are the people that we worry about, and those are the people that it's our job as doctors to catch and save. So the reason I think you guys need doctors like me, doctors who don't take insurance, is even if everything goes through in this terrible direction, there's still people who aren't going to be able to get care. There's still going to be immigrants, and we take care of a lot of Mexican nationals. They're not going to be able to get care. People need to be able to get a second opinion. That's almost totally gone from the medical community now. Most insurance companies do not allow you to see two doctors for one problem. There are a lot of people who can't or won't buy insurance. Either they don't understand how to do it or they don't believe in it. And then you guys who are opted out, you also are going to need doctors who aren't all opted in. So either way, we still need to have the freedom of letting people have a choice. So just remember that. Remember the 4 C's. We have some handouts on that. But the main thing is, I think, just like Dr. Brown said, keeping that relationship of the doctor and patient as pure as possible, letting the doctors actually care for the patients, and letting the patients actually care for the doctors. Thank you.
I'm Dr. Keith Smith. Like I said before, I'm an anesthesiologist in Oklahoma City. Thank you all for coming. AAPS is an organization that has instilled in its members through a completely uncompromising approach to the care of the patient since its inception, this attitude that the patients come first and period. And physicians like Dr. Madrigal have taken this so seriously that at great peril to their livelihood and their practice have walked away from third parties and are doing what is in the patient's best interest. I walked away from government money in 1994 and have not taken a dime from Medicare or Medicaid since. Never looked back. In 1997, I decided that I was tired as an anesthesiologist of seeing patients treated the way they were in the big hospitals. Didn't like the way the surgeons that I worked with were treated. The hospitals tended to run the really good guys off. And I particularly didn't like the way they were leaning on me to practice this ACO, managed care, 3-letter alphabet kind of practice. I just didn't want to do that. So a buddy of mine and I decided we could complain about this the rest of our lives or we can do something about it. So we bought an old burnout surgery center and started up and brought in really good surgeons, and it went very, very well. Over the years, we began to notice, though, that more and more people that did not have insurance would call and say, how much is a hernia? And as an anesthesiologist, I knew what I charged. I mean, I basically billed for my time. I would go to a general surgeon and say, how much do you want to do a hernia? And they didn't even know. So they began to figure out, okay, well, yeah, I guess this is what I'd be happy with. And because I was running this facility, I knew what the costs were. I knew what the supply costs were. So we started quoting prices. And this is way back. This is back in '97. Well, over a course of years, not only did we have a pretty good feel for what reasonable prices were with a margin, but we began to hear stories about what the prices were across town at the not-for-profit hospitals. Well, they varied from 8 to 10 times what we were quoting. And what we were quoting was a profitable amount. I never understood why the insurance companies worked so hard to make sure that we were never on any kind of list or in their network, but they wanted nothing to do with us. And quality-wise, I feel like our facility's unsurpassed. Price-wise, I know we are. I know it's lower than anywhere. So 3 years ago, I launched a website and put our prices online. And that was not what the big hospitals and big insurance companies had hoped that we would do. The result has, and one of the first things that happened is Canadians started coming. And that was a real eye-opener, because but what else do you need to know when people say, oh, the free market can't work in healthcare, or the Canadian system is such a wonderful system? And I'm sitting there in Oklahoma City, which is a good place to live, but it's not a beautiful place. I'm just sitting there in Oklahoma City, and people are flying down from Quebec and Toronto and Vancouver, and they're having their hernias fixed, or they're having a bladder surgery, or they're having their blown out knee from skiing fixed, because primarily they don't want to wait in line. Now, all along the northern border are all these cottage industries, these hospitals and clinics that have blown up to accommodate these Canadians from waiting in line that actually don't want to wait in line. But their prices were very, very high. So we were bringing Canadians in. Well, then the next thing I knew, people from New York and Florida. Alaska is incredibly expensive. Alaska is probably the most expensive. But people from all over the United States started coming to our surgery center because they knew that for their child to have their tonsils out, it was $3,100, and that was the surgeon, anesthesia facility, supplies, everything. And there's no bait and switch. And I have prices for, you look at our website, it's surgerycenterok.com, of prices for almost everything that we do at the facility is on this website. I began to learn more and more about the sickness in medicine that has been caused by the federal government. And part of the incredible sickness of the system, and I'm not one to defend the current system because it's essentially a cartel between the large hospital organizations and the giant insurance companies. And they're the same players that wrote this, what I call Unaffordable Care Act. That bill was written, its purpose was to line the pockets of those people, the big pharma, big insurance, big hospitals. They wrote that bill. Well, they are the current beneficiaries of the current system, and I'll tell you about two scams that most people don't know about. One is called the uncompensated care system, and it is a scam. Essentially, big hospitals are incentivized to produce large and fictional bills, amounts they know they'll never be paid, knowing that the spread between what they charge and what they collect would be submitted to Uncle Sam, who then fires a rebate back at them to the extent that they provide this uncompensated care. And it's the difference between their billed and collected amounts. So if you have nothing and you walk into an emergency room, you're actually more likely to get an unreasonable bill because that increases their take from the uncompensated care scam. The other thing that charging these giant amounts does is it allows the hospitals to maintain the fiction of their not-for-profit status, because they write, if they have a $100,000 bill and they collect $18,000, oh my gosh, they lost $82,000 and we're going broke, and aren't we feeling sorry for them? Well, their cost was probably $90 and they got $18,000 on that. So that's one thing that the federal government has basically allowed to happen, which has caused the price of care to just not be rational at all. The second thing most people don't know about is PPO repricing. This is an activity within insurance companies and PPOs that perversely incentivizes them to actually seek out the most expensive hospital or the most expensive group of physicians. And here's how it works. You go to the emergency room and you have abdominal pain and you have all these tests and all these things, and at the end of the game, your bill is $30,000. That is not, by the way, that is not unreasonable. The insurance company comes in and let's say you work for a big company like Devon Energy or somebody like that, and they come in and they say, the insurance company says, we worked them over. We worked them over, and we took that $30,000 bill and we whittled it down, and you only have to pay $10,000. So we saved you $20,000. Well, the way that the group health contracts are written, Devon Energy or whoever has to pay that insurance company a percentage of that false savings. The insurance companies actually make more money off of this PPO repricing scheme than they do on collecting premiums. Having said that, that is why it is very unlikely, I'm hoping I'm wrong, that we see a change in the tax code from up here. Because for individuals to have the same power to purchase health care with pre-tax dollars that companies now have, it guts that PPO repricing scheme. I know all this because my surgery center has been victimized by this whole scam. And that's why at a reasonable price, providing great care, we had trouble dealing with insurance companies. They wanted nothing to do with us. And you think, well, wait a minute. If we're a tenth for an anterior cruciate ligament reconstruction of what the big hospital is, why wouldn't the big insurance company want to use our facility? Isn't it just money in minus money out? No. They actually want to go to the place that's going to charge $80,000 for a procedure we charge $7,000, because the insurance companies actually make more money doing that. I believe that's one reason the tax code looks like it does, where employers have an advantage in purchasing insurance that individuals don't have, because that individual policies are not subjected to this PPO repricing. There's a couple of things maybe you didn't know about that I didn't know about until I started running my facility. We are going to continue to provide transparent costs and care to patients that seek us out. We're getting busier all the time. In a strange way, this Unaffordable Care Act is probably going to make us busier as more and more people fall through the cracks, as more and more people get in like Canadian-like waiting lines. Our surgery center, by posting these transparent and low prices, is probably going to get busier. But it's a horrible, horrible situation and a horrible idea to think that we could be going down the same path that the Canadians have gone down. Thank you.
We have some time for a couple of questions, and we'll take a couple, and then if we run out of time, we can stay around and answer some more.
I was just curious about the PPO repricing. When they supposedly save you that money, but you say they get a percentage of the difference. Where does that where does the money come from for the percentage? I missed.
It comes from whatever company has the arrangement with the insurance company. Let's say Exxon is self-funded. Let's say they've seceded from the normal insurance game, but they're big enough that they can actually pay their own health claims. So they're self-funded. Well, they have someone, a big insurer, administer that self-fund plan for them. And as part of that arrangement, whoever the big insurer is says, hey, we'll reprice these claims as a service to you, and for that we get 15%. And so Exxon or whoever, they then have to pay those amounts, which gives the insurer the incentive to go find the highest charges they can find.
Now, does this only work though for the companies that self-insure?
Yes. Oh, and actually, I'm sorry, no. No, it doesn't. If it is any type of group health plan that is provided by an employer, they're subject to PPO repricing fees. The ones that are easiest to see are the ones that are in self-funded plans.
Okay, but if it was not self-funded, then who is paying the percentage? Because
The company that provides the benefit to the employees, they'll have an arrangement where, and oftentimes it's shrouded with like an escrow account, and the PPO will say, you know, to the extent that we help you out with these claims, then at the end of the game, part of this escrow account is ours. So that helps pull the curtain across what's going on. Dr. Emmerling.
Of course, the uncompensated care scam was used to sell the individual mandate.
Yes.
As you know, all these people are costing the system so much money. Let's make them pay into it. And they're calling these people so-called free riders, when in fact they're getting ripped off to pay for everybody else's health care, and their use of health care is de minimis.
Keep in mind, the big hospitals, the deal they made to see all of the indigent patients back in the late 50s was that they'd be relieved of any tax liability. And the value of that number is incalculable, but they weren't satisfied. They pushed the uncompensated care scam, and they are making so much money. Yes?
My question is for the first doctor that spoke. Yes. You talked about it's fraud for you to see Medicare or to give free services if you're seeing Medicare, Medicaid patients. Mm-hmm. What law is that?
It's in the Medicare law. It's actually considered an enticement, and you can't legally see anybody for cheaper than you see Medicare patients if you take Medicare. So hypothetically, if you saw all your Medicare patients for free, you could see patients for free. But you can't legally see anybody for cheaper than the amount that you have to give Medicare the best deal. Do you see what I mean?
Do you know about what year this became into effect?
Do you know, Jeremy?
Not enough yet. No.
Yeah, I don't know how long that's been there. I don't know if it was originally when it first came out in '65 or if I don't think it's new. I think because almost all the insurance companies have a similar clause when you sign. That's why I never signed their things in the first place, because they almost all have a similar clause that says you won't give a better rate to anybody other than theirs. So you're kind of stuck all the way around between a rock and a hard place. You can't give people who don't have insurance a better rate than you give them.
I'd also like your opinion on the laws the state and federal laws that say hospitals have to treat patients whether they have the ability to pay or not.
The EMTALA.
Right.
And
the contradiction between taking the Hippocratic Oath.
What do you mean?
Well, why would you have to take a Hippocratic Oath saying that
You'll do no harm?
right if the government basically forces you to give care to people that can't afford it?
Well, it's not the giving care. It's not the. I'm not sure I totally understand your question. Ask your question again.
Do you see a contradiction between those?
You mean like kicking people out of the emergency room? Is that what you mean?
Well, do you feel that being forced to, if you were a hospital,
Mm-hmm.
being forced to treat patients, whether their ability to pay or not, it's an intrusion on your rights as a physician?
Yeah, hospitals don't take the Hippocratic Oath. I mean, I personally don't turn people away. You know, if people need care, I take care of them. So, and most of the doctors I know do the same thing. You know, and as far as, I mean, the Hippocratic Oath doesn't say see people for free, but it does say do no harm. And most of the doctors I know take that extremely seriously. That being said, I know some of the med schools are changing it, and they're not even taking the Hippocratic Oath anymore, which I also think is very dangerous. And we have a whole paper on that actually on the AAPS that Dr. Jane Oriented wrote about that. But again, I think that's a very dangerous way that the whole doctor relationship is going, that we need to rein those people back in and have them not be doctors and not have that type of a doctor be out there. Does that answer the question?
Well, as a healthcare LA, I just see, very conservative, I see an issue with forcing the hospitals to see patients. Because we're starting to see a trend at hospitals. People come in every single day who are hypochondriacs or just completely taking advantage of the system, or they go to the hospitals, they're not educated on more affordable ways to get care. And if the hospitals had the ability to say, no, we're sorry, we're not going to treat you anymore, you've taken advantage of us, that's illegal.
Okay, that I totally understand. Okay, and that is also in Dr. Brown's recommendation, and that is absolutely true. Like, we had an exchange student for a while, and when I was working in the ER, I was telling her about this person who came in with a nosebleed, and she was like, huh? She was like, oh my gosh, what did their family think? We don't have that there. We had to take care of him. But not having to see people with a nosebleed, I think, would be very beneficial, and it would free up more emergency room time for people with heart attacks, because the problem is if you have a whole bunch of nosebleed or stub toe people or drug seekers or people who need other things, you could actually take care of patients who need it. On that same way of thinking, if people have a reasonable price and these people can, because a lot of people say, well, I'll just go to the ER for free. In other words, they just won't pay their bill. Versus if they can come to see a doctor like one of us and pay $75, they can probably afford it. Go ahead.
I can maybe answer a little bit more. First of all, doctors are not obligated to see all patients. That's clear. You can turn away patients who disagree with you or you don't like for any reason. And hospitals under EMTALA, the emergency room must treat anybody that shows up within 50 feet of their door. But the hospital does not have to admit them. All right, they can deal with their problem and then send them away, and that happens a lot. You know, private hospitals don't have to admit somebody who is not going to pay for their care.
Yeah, but they do still have to see them and take care of them. And if they need to be admitted, they still have to admit them.
And they incur big losses, especially in the areas of the country where there's a lot of illegal immigrants, shall we say. They can literally break the bank of emergency room budgets.
I want to caution you, though, to not fall prey to the poor mouthing of the hospitals. Some of the rural hospitals are having trouble, but it's because of the big hospitals in the big cities that are sucking all of their blood out. They are ruining these rural hospitals by going in and buying the physician practices and making those guys the tool of the mothership. And so any patient that comes see them goes and gets turfed to the big city, and the rural hospital is devastated. These big hospitals desperately need every single person that comes through their emergency room door that doesn't pay them to make sure that these incredible profits, these billions and billions in profits that they're making, can be hidden. So I would just caution you to not fall prey to the poor mouthing strategies. Mercy Hospital in Oklahoma City, their mothership is in St. Louis. They went on a $4.2 billion spending spree in a 4-state area after they lost everything in the stock market in 2008. Now, something tells me they've overdone cost shifting just a little bit. Something tells me they're not having a hard time. They're buying up physician practices as in hostile takeovers. So I don't listen much to the, should they have to take everybody that comes in? No, I'm a free enterprise, libertarian kind of guy. Hell no, it's a business. They shouldn't have to do that. However, the deal they made was they agreed to do that, and in turn not pay tax. So I don't know, I'd caution you to have a little bit of a jaundiced eye when they're saying that stuff.
If anyone needs more information on the EMTALA reform in Dr. Brown's Option Act, you can just let me know. I have all that information.
By the way, Dr. Smith, under Obamacare, you and your colleagues could not form a surgery center or a hospital now.
Actually, you can. The restriction is on specialty hospitals. And the specialty hospitals, and they can actually form if they agree to take no federal money. But that is a very problematic thing. It's easier for us at the surgery center. What a nightmare piece of legislation.
And just related to that, I mean, are you starting to see more surgery centers do stuff that physician-owned specialty hospitals used to do? I mean, is there? You see what I'm asking?
Yes, the technology is progressing in a way that you're seeing more surgery centers do total knee and total hip replacements. For instance, there's a guy in Minnesota who's actually doing outpatient coronary artery bypass grafts off the pump. And I think as time has gone by, more and more surgery has been done in outpatient centers. I think it's 80% of surgeries now are done as an outpatient. I think
And
you'll
how
see-
long before the big hospitals start going after you for that, do you think?
Oh, they did from day one. It has continued nonstop. That's why in the Affordable Care Act, all of the restrictions on the specialty hospitals, they are in there. That was the gift to the American Hospital Association to get them on board. One of the many gifts.
Let's do one more question.
We're done.
Well, that's, thank you all for coming, and we'll stay around if you have any more questions that you want to ask us.
Thank you.